know. My name is Jamie Stutz, and I work with Dr. Agarwal on the CPC program at the Cancer Center, and I'm a faculty member in the Division of Medical Oncology. I've appreciated the opportunity to meet quite a few folks in the program, but still looking to meet more of you over time. And just a few updates from the Cancer Prevention Control Program perspective. We will be holding a virtual mini retreat this year due to COVID-19 constraints. And so you probably received some communications from Ellen with regard to scheduling and registering for that retreat. We also have another opportunity, a Cancer Center-wide mini symposium that has been developed to address one of our Cancer Center's cross-cutting themes, aging in cancer. And so we have a couple of slots on the presentation docket for cancer prevention and control investigators who study aging in cancer to present their research. You know, this is to bring together those investigators across programs who have investments in the aging and cancer space to extend the scope of that work. It is paired with a pilot funding opportunity that you've probably seen and received notifications of. But if you have any questions about either the mini retreat, the symposium that is coming up, or the pilot funding mechanism, please let Raj and I know, and we are happy to provide any additional information that we can to stimulate your participation or response to some of those opportunities. Most importantly, I'd like to introduce our speaker today, Dr. Marco Del Cairo, who comes to us from the Karolinska Institute in Sweden most recently. And he is a surgeon who serves as the chief of surgical oncology with a specialization in care of pancreatic cancer and pancreatic health issues. He is not only a professor of surgery, but he has a very strong program of developing guidelines for pancreatic cancer care and a translational research program that founded in basic science all the way through patient care and other concerns. And so part of, in addition to hearing about his research and some of his work today, one of the goals of it is to bring together a translational research group across CPC with investigators in different areas to expand and explore opportunities for translational pancreatic cancer research. So without any further ado, Marco, we look forward to your comments, and we'll have hopefully some time for some questions and explore opportunities for collaboration towards the end. So thank you.
Thank you very much for inviting me, and thank you very much, I think, for what you are doing. I actually believe that this group you put together is one of the really key in the modern vision of cancer. We saw in the last decades, I mean, dramatical changes in cancer prognosis in general. I think very much important changes even in pancreas cancer prognosis. But my opinion, and that's maybe seems to be strange for a surgeon saying that, but my opinion is it's much better to prevent or to early treat than treat. So I think for pancreas cancer, it should not be different. Even if we start to approach a prevention to pancreas cancer, I think probably pancreas cancer is behind mostly of the other cancer from this point of view. And I try in my presentation not only to focus on my research, but just giving a picture of what I think are the problem and limitation regarding the prevention of pancreatic cancer. And that will be mostly on the first part of the presentation. The second one, I will mention other problems related to the topic I want to focus today. But I think that will be probably more boring part for you. So we can maybe short this one. And also, I don't know how is your format normally, but please feel free to even stop me during my presentation if you have something come to your mind. I'm here with many questions, very few answer, and I'm here to learn by you how to improve my practice and especially how to improve the care of my patient. It's true, I had several collaboration translational research, but I don't have a background in basic science. So I'm just a very curious clinician, mostly focused on clinical research, then try to learn by basic scientists through making question and being very curious and intrigued by the answer that basic scientists can offer to our question. Let me see if I can, yes. So this is probably a picture that you know extremely well. But this, I think, our picture is extremely important to define why it's important to focus on prevention of pancreatic cancer. On one side, on the left side of your screen, you see that pancreas cancer represents a small percentage of cancer in the United States. So why to focus so much attention on pancreatic cancer? Well, because even if this is a very small percentage of all cancer in the United States, this is the #3 killer cancer in the United States, and is expected to become the #2 in 2030. So beside a pretty low incidence, pancreas cancer kills almost every patient affected by this disease. And that can be explained by several aspects, but the baseline is that whenever we make a diagnosis of pancreatic cancer, it's too late. Whenever we make a diagnosis of pancreatic cancer, it's a systemic disease. Even when we don't see spreading of the disease, it's still a systemic disease. And it is, I'm very intriguing sometimes to discuss, even in a provocative way, with my young trainee and say, I never saw a patient dying for local recurrence of pancreatic cancer. All patients with pancreatic cancer die for distant metastasis, which means that whatever surgeon can do is never curative. The patient die even if you remove everything in a very radical way. They die for relapse of disease in other organs. So that's the baseline. We need better treatment, but definitely we need to keep pancreas cancer, to diagnose pancreas cancer earlier. This is actually was posted this year on Pancreatic.org, but let's say that was invading for the 2019 World Pancreatic Cancer Day, the web, because finally, after many years, we reach a 5-year, 10% survival for pancreatic cancer patients. Okay, so tell me which other cancer, which other solid cancer you know with this kind of prognosis. And that was considered a great success because we went from 0 to 3 to 4 to 5, finally with 2 digits, 10%. Great success, great improving survival, but still very poor and definitely not enough for what we want for our patient. Now, how is the process to develop pancreatic cancer? Until the late 90s, beginning of 20s, we believed that that was the only way. So pan-in transformation from low-grade dysplasia through invasive cancer in a process that is approximately estimated about 10 years. So many steps in between the low-grade dysplasia, the beginning of the process of carcinogenesis, to when pancreatic cancer become clinically visible, but unfortunately, just an histological progression that cannot be detected by any kind of imaging. And the reason is in these slides. So what pan-in looks like? Pan-in looks like what histologically we can define as lobulocentric atrophy, but morphologically at imaging, basically nothing. So you can have up to high-grade dysplasia in the pancreas, but you don't see anything. And that's probably was the major limitation to develop any kind of surveillance program, even in high-risk individual. So you don't see anything until it's invasive cancer, which means for the biology of pancreatic cancer until it's too late. And the patient has already a systemic disease. If you want to prove of that, I have some data that will not be the major topic of today's discussion, but just to let you understand how much up to now was complicated, the problem of prevention or early diagnosis of pancreatic cancer, and why many places that also invested enormous amount of resources, they give up to investigate in this area. So who is at risk for pancreatic cancer? You teach me that whenever you decide to open a prevention or surveillance program, need to be worth. means that, the cost benefit need to be evaluated. So you need to have enough risk to justify a screening. And also you need to have targets that you can detect when you do the screening. On the left side of the screen, you already see that the normal risk factor for cancer are not working very well on pancreatic cancer. If probably we make an exception of chronic pancreatitis, which in my opinion is a fake data. Because, and I will tell you later why I think is a fake data. These are historical data when some other disease were called chronic pancreatitis, but actually were not chronic pancreatitis. So this estimation of risk associated with chronic pancreatitis or pancreas cancer, I think is overestimated. Do we want to do research on that and confirm what I'm saying? That's another interesting area, but will not be the topic of today's discussion. In the other part of the slides, on the right side, we have actually a very intriguing problem. The problem of genetic risk of pancreatic cancer. I have to tell you, and I will not show you that, but this is actually was one of the really first area of research I invested when I was still in Italy. And I was still a resident when I opened the Italian registry for familial pancreatic cancer. And I was really believing a lot on that. But here, after many years of research, and in the University of Colorado, we have a very brilliant program for this aspect, but there are two major problems. One problem is that beside the few, which represent a very small percentage of patients, very well-defined genetic disease, like for example, BRCA mutation, P16 mutation, wherever you want, in the typical familial pancreatic cancer, we don't have a gene mutation. So we need to stratify patient at risk just on the statistical risk to develop cancer. So first problem is we have a patient, he has a statistical risk based on number of family members affected, but we don't know if this guy really has a genetic predisposition. Number two, we believe until a few times ago that this lesion, the perineoplastic lesion, were invisible. So many screening protocols were done in the world, but at the end of the game, when you went to see what those kind of screening program leads, we saw very debatable results, very different results in terms really of what was working and what was not working. We can see in these slides several surgical programs on familial pancreatic cancer risk, showing accuracy in detecting malignant lesion or high-grade dysplasia from 100% to 20%, 16%. And here I think is a matter of philosophy. Someone did surgery only when they identify cancer, but that's probably too late. So it's not an effective screening because the patient still will not receive probably survival benefit, and someone that had a pretty low percentage of malignant or high-grade dysplasia lesion in which we overtreat a significant amount of patients that probably never need a surgical resection. Now, what I will focus today more my attention is something that is, in my opinion, really very important for the future. And again, I'm taking a lot of time in this first part of the presentation, and I have no problem to cut the second part that I just put there in case it's needed, but really I'm not very interested on because that is more surgical oriented. So we identify some lesions that in the past we didn't know at all, or actually we ignore, that are the cystic tumor of the pancreas. Cystic tumor of the pancreas are a large variety of lesions. Half of them are represented probably by Ipmns. And then we have other lesions like MCN, a serous adenoma, that represent about 20% each, solid pseudopapillary tumor 6%, and all the other, and are really many, represent only 8%. Now, I focus here on this slide attention only on the more common of those lesions. And as you can see, those lesions has a very different biological attitude. For example, Ipmn, we already told the most common, is a real precursor of pancreatic cancer. But compared to panin, there is a big advantage. You can see by imaging. You see cyst in the pancreas. So it's something visible. It's not invisible like panin. They can progress to cancer. Follow-up of those lesions are required, and surgery is possible in some cases. MCN also is the precursor lesion of cancer. We need to follow those patients or resect. SPN is very different from the other cystic lesion. So yes, need to be resected, but it's easy to recognize. Serous adenoma, in contrast, is always benign, need surgery only occasionally when give symptoms, but the problem is how can be sure we are dealing with one or the other of those lesions. The second problem is how often we can find this kind of lesion in general population. And up to now, we believe was around 10–15% of population. But there were a retrospective study done with the diagnostic modality not specific for pancreas. This is the first prospective study done in Germany and published 2 years ago in Gut, analyzing more than 1,000 healthy individuals that underwent a specific pancreatic MRI. And this study showed that 50% of population has cystic lesion of the pancreas of every kind. It's a great news because we have a target that potentially we can follow, but it's a bad news because if we are not able to understand which one and when can be associated with cancer and which one we can't forget, that means that potentially we need to do follow-up in 50% of population. Just to make a number concrete means under 50 million of Americans, which is clearly not sustainable by economical standpoint, which means that we need to discriminate who needs or who don't need a follow-up. Now, everything seems to be easy up to now. Well, check these two cases. On the upper part of the screen, you see a cyst in the pancreas, and you see the same cyst in the tail in the lower part of the screen. Is that correct? So these two patients today probably will never receive surgery because the characteristic and the idea to do surgery are different today. In the past, every cyst was removed, and the histology show in the first case a serous adenoma, so benign lesion that never progressed to cancer. In the second case, an MCN, a disease that progressed to cancer. But radiologically, we're looking exactly the same. So you understand that it's very risky to make a decision in something that appear radiologically the same, but biologically can be extremely different. This is a study I did a few years ago showing that even in high volume experiences center, the accuracy in diagnosis preoperatively is extremely low. Is around 60% and goes up to 65 if we include only the latest year where diagnostic were better, but still remain extremely low. So we can say 1 patient every 3 we make a diagnostic mistake. And here you see the importance of mistake change according with different diagnoses. But very intriguing is that if you compare different modality of imaging, nothing changed in terms of accuracy of diagnosis. So even when you sample the cyst with FNA, even the analysis of the cystic fluid doesn't help you to increase your accuracy. Let's start with the most common, and I think more important between all the cystic lesion of the pancreas to be analyzed, the Ipmn of the pancreas. This is actually very important because it's a macroscopic, the visible, the not invisible precursor lesion of pancreas cancer, like is Panin, which is another of the path in which pancreas cancer can rise in the pancreas, but in this case it's visible because it's a cystic lesion, it's a dilatation of the duct, it's something that is detectable by our technology. The progression model is very similar to the one that you can observe for Panin. So you go from low-grade dysplasia to invasive cancer through different kind of grade of dysplasia. Today, both low-grade and medium-grade were put together in the new classification low-grade, and then you have high-grade dysplasia. It is important to detect this lesion early. Yes, it is, because when you see basically an Ipmn which is not invasive, so no cancer, the chance of survival if you resect are excellent compared to when you have cancer where your chance become extremely lower. The best we have today, I have to tell you, and I will go through many other options, but the best we have today is still a classification, and I'm proud to say that from an Italian radiologist, Procacci, which divide Ipmn in branch site, which has a very low risk of cancer, and main duct, when the main duct of the pancreas is involved, in which cancer is much more frequent. After basically 20 years from this classification, is probably still the best we have today to make our clinical decision. Those are the evolution of the European guideline, and I use the European guideline because the latest one, in fact, are world guidelines, because groups even from America and Asia were involved, and also because I'm proud, I founded this group in 2011, and we shift from expert opinion in 2013 to really evidence-based guideline in 2018. where we try, based on the low level of evidence we have, to make some change in the indication for surgery. First of all, in branch duct, we believe in the past that the dimension of the cyst was important. Is not anymore the case. This is a study we did 2 years ago with Hopkins, analyzing almost 800 patients with a cystic lesion. The cyst diameter over 4 centimeters was not associated with any increase, alone was not associated with any increase of risk. In contrast, some marker like CA99 could suggest us the presence of cancer. Mural nodules can be a risk factor in this patient, especially when they are enhancing and over 5 millimeters in diameter, and they can lead to have surgery. And here is a resume of which kind of characteristic can be more associated with the risk to develop cancer in Ipmn patients. But another very important issue related to what we told before, okay, we have an Ipmn, we don't found the characteristic to take it out the Ipmn, should we follow this patient lifelong or not? This is interesting because international guidelines and European guidelines say, yes, you should follow lifelong, at least until the patient is fit for surgery, once American guideline told, no, we can interrupt the surveillance. And it's very interesting because the two guidelines approach the problem differently. The Americans say, do we have strong evidence we should follow? The answer is no. But the European international guidelines say, do we have evidence we can stop? And the answer was no. I show you a couple of pictures. This is a case diagnosed in 2008 with small cystic lesion, stable in 2013. So for the American guideline was enough to stop the follow-up, not for European international guideline. And after 8 years of surveillance, the patient developed cancer. Here you have a paper. This is a paper from my previous group, but there are several other. This is another Italian group, and this one is the Memorial Sloan Kettering, showing clearly that the risk of a progression of those lesions increase over time, which is pretty logical. We are dealing with the dysplasia, so clearly the longer time we wait, much more risk we have of progression. So follow-up cannot be discontinued according to our current information, but that is impossible. So a big step here, we need to identify some biomarker, we need to identify some marker in general that tell us who is progressing, who will never progress, and make a good use of resources, stopping the follow-up in patients that probably never need follow-up, and just giving follow-up in patients that can benefit for follow-up. This is a huge step. We are even not close to start to understand how to do that. And this is a huge area of research. When there is duct dilatation, there is, in contrast, a strong indication to surgery. But even there, you will see maybe 70% of patients that go to surgery has high-grade dysplasia or cancer, but 30% still probably receive an overtreatment. So we are much more accurate in duct dilatation, in making the right choice, but we are far to be perfect. And even there will be probably important in the future to say, okay, you have a duct dilatation, the same diameter of duct dilatation, but really you need surgery or you don't need surgery. And that's another area for sure in which we are very far to understand the truth. Even here, guidelines give different recommendation, which kind of diameter is the cutoff. And all the data, and I will show you some in the late literature, say that already with 5 millimeter duct dilatation, surgical approach probably is indicated in the majority of patients. You see here some data of literature, but I show you some study. This is probably the first one, show the problem of the 5 millimeter duct. This is a study from Germany, showing that already from 5 to 9 millimeters, 60% of patients had already invasive cancer or high-grade dysplasia. This is a paper from UCLA saying 7 millimeter cutoff is probably the best cutoff. This is a paper from Karolinska when I was there, validating the 6 millimeter of the previous guideline. And this paper done together with Hopkins confirmed the importance of the 5 millimeter dilatation of the duct and over to catch high-grade dysplasia and cancer. But still, as you see, we are using very rude risk factor and metrics to define indication for surgery. There is never mentioned biology in this kind of slides. So we are really in a prehistoric area of treating preneoplastic lesion, considering also that what this patient need to be done is a pancreatectomy with high morbidity and mortality. So clearly we are dealing with something that need to be investigated further and hopefully defining better biological markers that drive our surgical or non-surgical approach. Very intriguing, and that's, I think, is one of the slides really I like more, is that when you use morphological aspect to define markers, we have a limitation. So one of my idea is that in a preneoplastic lesion, I don't want to operate when it's already cancer because it's too late. But I don't want to do surgery when it's low-grade dysplasia because it's too early and it's probably never treatment. The best would be to catch the high-grade dysplasia. So using the fact that we had 1,000 patients resected together with Hopkins, and we had a large collection, I thought, okay, let's have a look if we identify a cutoff that help us to discriminate high-grade dysplasia by cancer so that I can treat in the right timing for surgery. Not too late when it's already cancer, not too early when it's still like low-grade dysplasia. And as you can see here, it's impossible. You have a very big delta between low-grade dysplasia and cancer, around 5-6 millimeter, but high-grade dysplasia and cancer remain very close to each other. So we cannot really get the best target using only morphological criteria. We need something more that go over morphological criteria. And here just to say that the paper suggests that the best cutoff in order to catch high-grade dysplasia in cancer is between 5 and 7 millimeter in that dilatation. Now, I'm going in a part that I think is less interesting for you, but there could be maybe some area of, and some aspect that could be argument of discussion, even for further investment in research. Okay, let's imagine that you have a case of main data Ipmn. We learned that the main data Ipmn, is associated with a very high risk of cancer. But what we don't know is when you have, like in this patient, a DAT completely dilated, all the pancreas is sick, or the sick part is in the head, that's causing obstruction, and the rest of the gland, the DAT is dilated just for hypertension, but in fact, there is no disease. That makes a huge difference because it means removing all the pancreas or removing only one part of the pancreas. So because of this problem, our guidelines suggested to do a Whipple, so remove the head of the pancreas, and then investigate with a frozen section analysis during surgery if there is disease, even at the level of the margin. And very intriguing is that beside the guideline, a few years ago, we did with the Dutch group a very interesting survey, including the best center in the world in this topic. And beside that, in 46% of cases, we simulate case, people were doing total pancreatectomy without investigating further if there was disease in all the gland or not. So imagine a patient had the disease only in the head, remove all the pancreas with all the problem related to unstable diabetes, brittle diabetes, and so on. And the problem is a huge problem. So what did we do now generally with the removed part of the pancreas? We send a slice of the pancreas for frozen section, and wherever is there, for example, no disease or low-grade dysplasia, okay, we are happy just doing the Whipple. If there is high-grade dysplasia or cancer, we extend the resection. That does work? No. Because still in those patients, when you observe what happens over time, you have a pretty significant number of patients that has progressional disease in the part of the pancreas to live there, even if the frozen section is negative. So you don't see disease. Why? Well, this is actually a very intriguing point. And data are not, let's say, similar in every paper, but very, very important. This meta-analysis published in 2016 on 1,500 patients show the frozen section, so what generally we do every day in surgery, is not correlated with a better outcome on the other part of the pancreas remaining there. So it's not significant in making decision. Why? Because Ipmn can have skip lesion. So you have a picture at the level where you cut the pancreas, but the situation a few centimeters behind there can be different. So you can have cancer or high-grade dysplasia at this level. You don't catch with the section of the pancreas at this level, and the tumor can grow here a few months later, a few years later, after you did your resection, and you was happy because nothing was present at this level. without annoying you with surgical detail, one thing we did, and actually we are going to publish now the retrospective study we did, and we launch an international prospective study. We started to explore the pancreatic ducts with an instrument, which is a pancreatoscope, trying to catch lesion along the duct and personalize the resection according with the situation of the duct. You see here some disease, this small bulging on the mucosa, on the epithelium are disease. You see here the duct is normal, but a little bit further you see again disease. So in this case, you cannot save pancreas. In other case, you can do that. This actually approach was very useful to change our strategy in about 1/3 of patients, but still is based on visual imaging. We don't have any possibility to have a, let's say colorant that can potentially be linked by these cells according with different grade of dysplasia that give you really a perfect visualization of which kind of dysplasia you have along the duct, and then really treat what need to be treated or not. So again, we are at the prehistoric area of something new, better than what we had before. We can today explore during surgery our duct. We can personalize the resection margin, but that is made on our eyes, on our experience, or what our eyes see, and sometimes that is not correct because it doesn't correspond to histology. Here I have a few other slides related to other kind of cystic lesion. If you agree with me, I will skip and I will focus my attention on the last part, which is the translational research part I did in this topic. And I will prefer, if you agree with me, to leave a little bit more time on the discussion because I'm curious to interact with you for potential collaboration in the future. Is that okay? Perfect. Okay, so one of the really intriguing point here is the following. We have two major problems in this topic. One is which kind of cystic lesion I'm watching. Is that an Ipmn, which means potential progression to cancer? Is that a serous adenoma, benign disease that doesn't need surgery, either follow-up? Is a huge problem because besides to make mistake over or under treat patient, we are also trashing a lot of money for the follow-up of all those patients. And then you can say, okay, but why not doing cytology? Why not doing, this kind of stuff that we do in many other diseases? Because it doesn't work. And here are the numbers. So endoscopic ultrasound and FNA has a sensitivity of 47% and accuracy of 64%. When you do an aspirate cytology, 38%. When you combine biochemistry and cytology, the correct diagnosis is in 33%. Plus, those kind of procedure potentially has even risk. So paradoxically, traditional radiologies may be more accurate than cytology in cystic lesion of the pancreas. So this approach, unfortunately, at the moment is not extremely useful. So a few years ago, and I apologize if I will not be precise in that, because that's actually is, again, I'm the clinical part of this research. We decided to investigate in metabolomic. And we decided to investigate in metabolomic both in the serum and in the plasma and in the cystic fluid. I have to tell you, this is only the preliminary paper we did. There is another paper, and I'm proud to say that was done with the metabolomic core facility at University of Colorado, which has a technology much more advanced than the one we did when I was in Sweden, and we found even more intriguing results that I hope we will be able to publish very soon. But basically, the point here is that we identify, very intriguing results. Because using metabolomic, what we identify is that we were able to have basically 100% accuracy in discriminate the serous adenoma, so benign cystic lesion versus other cystic lesion. We were able to have an 89% accuracy in defining low-grade dysplasia versus all the other kind of tumor. Very interesting, we identified the possibility to have a 90% accuracy in high-grade dysplasia and cancer together versus all the other cystic lesion included, and also 100% in discriminating Ipmn which are the lesions that can progress to cancer, versus serous adenoma, which are the one that never progress to cancer. So that's actually was extremely interesting. The limitation of the study is that the number were pretty low. And so now we run again a study with a more sophisticated tools, including more patients and also looking more carefully in detail about metabolites and lipidomics results and identifying even potentially new marker. And I hope really I will have the complete data in a few days. I had a meeting with Angelo D'Alessandro a few days ago, and he explained me that the result seems to be very intriguing. Now, this is probably, in my opinion, the more intriguing research that in this topic, translational research in this topic, I did. And I want to tell you a little bit the story about that. So a few years ago, I did an epidemiological study. The background was that there are several papers saying that the prevalence of this lesion of the pancreas, this Ipmn, is higher in people with other cancer. So people were looking for an association between Ipmn and other kind of cancer. And it's true, the prevalence is higher, but for a bias. Being a very common disease, you get colorectal cancer, you do a scan, and you found this cystic lesion that generally are asymptomatic, so you don't find in the people without any other cancer. So we did an incidence study, and we identified there was no increased incidence of other cancer in Ipmn patients. But what we observed that in a subgroup of males, there was an increased incidence of gastric cancer. So I made a mistake, and I thought, okay, I understood. The cause of Ipmn is Helicobacter pylori. And I asked to a lab at Karolinska to investigate the presence of Helicobacter pylori in the cystic fluid of those patients. And what they did, actually, they told me, well, you know what? Let's start with bacterial DNA. Once we found eventually bacterial DNA, we investigate deeper which kind of bacteria is associated. And very intriguing, we identify bacterial DNA and with an increased concentration according with different grade of dysplasia. But we did identify Helicobacter pylori. So I was wrong, but actually the idea was very intriguing because, and I will go now through. So basically, we made this analysis in cystic fluid, both and in plasma. We have also some other results now. This paper was published in Gut a couple of years ago. But what is intriguing here, we identify a different kind of a distribution of bacterial DNA according with the grade of dysplasia in Ipmn, both related to low-grade dysplasia or high-grade dysplasia. And also, we went deeper in trying to identify which kind of bacteria were responsible of this increased level of bacterial DNA. And we identified that fusobacteria were extremely associated with the different grade of dysplasia in Ipmn. This is intriguing for several reasons. Fusobacteria are already described in colonic cancer, and there is a paper actually lately, I think this year or last year, from MD Anderson, seeing fusobacteria associated with pancreatic cancer. Now, the big question here is, if this observation we did is just an observation, or there is a cause-effect relationship between the fusobacteria infection and development of cancer in Ipmn patients. And this is, in my opinion, a huge step, because you can understand better than me that, I mean, if we can demonstrate an association between, cause-effect association between fusobacteria and Ipmn progression, we could potentially make a chemoprevention with antibiotics of patients with Ipmn in order to try to prevent pancreatic cancer in this population of patients. This is actually was all, and I'm more than happy to discuss with you about wherever you think is useful. And